All right, here we go. So episode 24.
Boom.
We're back.
Getting after it.
So it's been a long night for me. I had a late night call on the computer, so I'm gonna pound a bit of coffee this morning and we'll get after it.
Yeah, you messaged me probably only 12 hours ago. You're like, hey, what do we want to do for tomorrow?
Yeah, I'm feeling a little bit weary-eyed this morning, but let's do it, man. Last week we talked about my back injury. So that was interesting for me to kind of trawl over those details again, and hopefully someone's going to find that interesting. Maybe someone that's had some back pain and they're kind of thinking about what are the steps that I need to take to stop this from getting worse potentially. So we're going to continue on that path a little bit today because there are some things that needed to happen earlier to correct some of those functional problems in my low back and hips to kind of stop that problem continuing to develop. We know that dealing with that effectively is not done commonly. It's something that we focus on, but it's just not done commonly. And so, I guess this is an opportunity for us to explain what that is a little bit, because that's the vehicle that we've got here for the 10 or so people that listen to this show. But that's our opportunity to be able to explain that, because it is different and it is a bit specialized. It's a shame that it's that way, but I think that's our opportunity to share that. So, Mike, I guess, let's go. What are your thoughts on that?
I mean, we look at things differently than other chiropractors, even for something as simple and as common as lower back pain, right? A lower back that comes into our office is handled much, much differently than a lower back that goes into any other conservative care, non-surgical pain clinic on the planet. And it's important for people to realize what we're thinking. It's important to understand why we're different and how those differences can actually turn a case like yours, right? Somebody who, we could have saved from surgery. Like, let's be honest, we could have saved you from surgery and permanent, neurological deficits had you come into one of our offices. And it would have been some crazy, fucking hot tub time machine thing where you'd had to go into your own office in the future or something like that. You know what I mean? But what we would look at, what we would see, that would be an indication that you're dysfunctional and how we would go about fixing that. So, I mean, first and foremost, understanding from a symptom set standpoint, like right off the history, what you've already got going on. And again, remind me what your symptoms were at the very, very beginning.
Yeah. So mostly, I guess what you commonly describe as like non-specific low back pain is kind of where that had fit. So it's kind of that diffuse achiness in the low back area. For me, it was kind of one-sided, but you get that sort of radiating pain that had come around the hips, and it had kind of come around that glute area and through the front of the hip. That's, that what we know is sclerotogenous pain, but it's kind of that way to describe it.
And right off the bat, depending on where you're pointing to, what you're describing to me now is an L4, L5 sclerotogenous pain referral pattern, probably some L5, S1 in there as well. So right off the bat, as you come into my office and I say, imagine you have a paintbrush, right? I want you to paint the skin of exactly where you're feeling it. And you're painting, right, two very well-known sclerotogenous pain referral patterns. We know it's one-sided. We know that it's sclerotogenous from a deep, achy, diffuse standpoint. So right there are my two big indications that there's something going on from a compressive standpoint in your lower back, particularly L4, L5, S1, is just that symptom set. So right off the bat, my head is screaming, right? Disc irritation, discompression, adhesion of the lower back. So without even asking any other questions, right, we pretty much know what the hell's going on just from, the first few parts, right? The site, the intensity, and the quality of your symptom set, right? If we go to SICK or AAA. So yeah, right there we know, okay, let's look to see, let's move to our exam, and we're going to examine your lower back. We're going to examine your hips in a way that's completely different to everybody else, right? We're not scoring it based on whether it's a pass or a fail or a moderate pass. We're scoring it functionally as a school grade, right? Not a pass fail, but a 60%, a 70%, 80%, and 85%. We're doing that with your hips. We're doing it bilaterally. We're comparing that. And then what we're doing, right, and I'm getting excited right now, is we're taking that objective data, we're reflecting it back into what our hypothesized diagnosis is from the actual history, right? And we know that somebody with a disc compression is probably going to have, at the very core, some lower back dysfunction, right? We're the only people that measure actual function of lower back. So if you take nothing away from this podcast, just understand that we're the only people physically measuring your lower back in isolation.
Yeah, there's, I guess, 5 really foundational functional movements of the low back and hips that we want to assess right off the bat. So these, we might drill down into some further testing if required, but there's 5 really basic foundational movements that we want to understand what their function are. And there's tissues that map into allowing this function to occur. So it tells us a lot, right? So we're basically looking at the hips to see, can the hip flex? So that's, can the knee come up towards the chest, and can the thigh meet the ribs easily and without symptoms? In my case, yes. Very, very mild impingement on one side where it kind of right towards the end, but otherwise it was pretty much full. The other way that we check the hip is, can it extend? So that's, can you take the leg backwards and extend out what we kind of call like the hip flexor? So can that lengthen properly? Again, in my case, yes, it was totally fine. You get a 12, 13 inches worth of movement. So not a problem there. And in a lot of cases, at least that I see for low back, that's often the case. The hip is generally flexing and extending quite well. So cool. Hip's kind of pretty good from that sense. The other part of the hip that we need to check is the mobility of the sciatic nerve. So we need to do a straight leg raise, which is a very common tool that's used in musculoskeletal care, but it's uncommonly used in the way that we use it. So we're actually looking at this in terms of the mobility of your sciatic nerve to be able to move properly, which allows your lower back to be healthy. It allows your hamstrings to have full mobility, and it allows you to be able to bend over and to be able to move properly. What we see often is that it doesn't happen like that. There's often some entrapment there. There's often some problem where that nerve can't move, and it causes problems. For me, in this situation, I had adhesion of the sciatic nerve. So it was stuck down at the hip on the left side, and it was also stuck in the hamstring. So it was in 2 spots there. So what that means for me is that, it explains why I've had tight hamstrings for such a long, long time. And I've been working out that way at this point for a long, long time, which means I'm moving inefficiently for a long time. I'm weaker on that side. And probably I'm having to bend through my low back a lot more when I'm lifting things because of my shitty mobility in my hamstrings. And that's happened over a long course of time. So that was a big one for me. That flagged all over the place. It was short, very, very stuck.
Do you know what your measurement was approximately?
No, I mean, I would have liked to know what it was sort of before things really blew up, but I had no idea. Yeah, unfortunately.
Yeah. And that's something that we would know, and we would be able to compare that measurement to all the other measurements that you have. So you'd have functionally a report card for those 5 tests, right? How well does your straight leg raise? How well does your hip flex? How well does your hip extend? Can you touch your toes? And I guess the last one that we haven't talked about yet, right, is how well can your back flex, which is the test that rules them all. essentially. When we look at that for a lower back patient, it's always short. And again, you're always going to have some, multiple issues contributing to a problem. And in your case, you had left straight leg raise deficiency and likely lower back flexion deficiency. And so for us, it's, what's the most clinically relevant? What's the worst one that we've got to take care of first? And you can only achieve that by having tangible data, tangible measurements to go off of. So if your straight leg raise was 80% and your lower back flexion was 60%, and we clinically correlated that the lower back flexion fixing that would drive you a greater change from a symptom set standpoint, then that's what we attack, right? So that's how we look at then the exam, right? The functional testing part of the exam differently than anybody else. First of all, we have really good data from the history. We've already got 90% of our diagnosis done at that point. We're just confirming, and we say, okay, does the what we find in the functional test, does that correlate back to the exam? Are those two in alignment, right? To use a classic chiropractic term, in alignment. And yeah, in your case, I would have been shocked to see your lower back flexion be anything better than 70%.
Yeah, let's explain the flexion testing a little bit, because this is a key component of what we do that is different, because there's no one else that really checks this with this level of detail, and definitely not from the perspective of the tissues that might be restricting it, other than, is there a flexion restriction at that joint? So we're not looking at that. We're looking at what's going on with the tissues at a very detailed level. But so when Mike mentions that we're looking for the spine to be able to flex, we're actually checking to see that you can create that curve in your low back. And that sounds like, yeah, of course, you should be able to do that. But when you actually really look at that close up and you actually measure it, a lot of people can't do it. And right. So what that means from a biomechanical point of view is that the structures that should be able to distribute the forces quite evenly within that block that should flex, they kind of get crushed. So when you're going forward and bending forward, and let's say, like, use an example of deadlifting, for instance, where there's, bending forward and picking things up and moving like that, a normal sort of small amount of flexion and normal small amount of movement that's well controlled by strong muscles either side of it, that force should get evenly distributed within those structures. But what happens is, when things can't move properly because the tissue's in a shitty way, the muscles are not strong, they can't lengthen properly, things go bad. So we're getting a bit technical here, but essentially like the axis of rotation changes in the mechanics within those segments. So you get things that are loaded that shouldn't be loaded. And over time, that starts to wear down. So what we're looking for is, you've got 5 segments in your low back, and we're looking to see which ones don't move the way that they should. And that's not necessarily looking at the joint and just springing the joint. And you may have had a chiropractor may have done that, and they may have sort of gone, oh, your L5's not moving properly here, we need to adjust it. It's not that. So we're actually looking at, can this move? Can this open? If not, why not? And then we need to go and actually feel those tissues. We need to actually find out exactly where that tissue isn't healthy and start reversing that. And let me tell you, you cannot fix it with an adjustment. And it's not to shit on an adjustment. I've been adjusted a lot, but it doesn't fix this problem.
Yeah, I mean, you're looking at assessing each individual vertebrae, and it's a team of 5. So anytime one team member is not doing their fair share of work, it puts more pressure on the other 4. And you functionally turn your vertebrae into what should be seesaws, or should have a nice even ding dong as you go back and forth, to nutcrackers, where you're basically putting all that force posteriorly through the actual joint. And again, it's it's understanding that in relationship to what's going on with the symptom set, with what's going on with the other tests, and then reflecting that forward and going in and actually palpating. Right? Why is the lower back only 50%? Why is it only 60%? Is it because of adhesion? Is it because of arthritis? Is it because of protective tension? And we're constantly crunching this data in our head, and we say, okay, we've got sclerotogenous pain referral patterns, we've got history of back pain, we've got a 60% quadruped lumbar flexion, and I go and I feel adhesion on the left side, and it's mild to moderate. Right. That all makes sense from a clinical standpoint. And in understanding that, now we actually have our complete and accurate diagnosis after all that work. Right. And we're pretty much 45 to 60 minutes into an actual treatment plan, or not an actual treatment plan, an actual first visit. And now we have that 100% full understanding of what's going on. And you may get to that hour point and still not know. You may need x-rays. You may need an MRI just to be 100% certain. But it's first of all, understanding the symptom set. That's going to take us 90% of the way there. And just knowing that fact is going to put us ahead of a lot of people. But we take great pride and great value from getting to 90% certain to 100% certain, because our patients deserve to know at a rate of about 100% of what their issue is, right? That you deserve to know. You would have loved to have known that, hey, you've got mild adhesion in your sciatic nerve causing entrapment. You've got moderate adhesion in your lower back. That in itself, that value of actually understanding that and not just being pushed around to different providers is going to be life-changing for you. And then we haven't even gotten to the treatment, right? Where we can utilize that treatment to say, how is this sclerotogenous pain referral pattern going? Is it lessening in intensity? Is it lessening in size? Is it something that you feel less frequently? Is your lower back going from 60% function to 70% function? Can I palpably feel a decrease in your adhesion, right? Both from I guess a square inches or square centimeter standpoint. What's the size of the adhesion? Is it reduced? How about the intensity of the adhesion? Is it reduced? Is it more compressible? All of that goes into what we are interpreting on a day-to-day basis. And that's really what sets us apart as doctors when it comes to back pain. We know exactly what's going on and we know how to fix it. And if we don't know how to fix it, we get you to somebody that can fix it. And that's it.
This was essentially what was going on with my back. And this is common, you get in chronic back pain cases, and a lot of them are going to show up with having a poor ability to flex the spine, and often some sort of involvement from sciatic nerve entrapment as well. So those were my two primary problems, right? And so once we start reversing that, things start to feel better. That's just how it is. And it's not a come in once, get it done once and you're good. It is a bit of a process. For me, that occurred over about 8 weeks. And it's got to be consistent. And you've got to do the right things within that 8 weeks, because the whole idea of treating that is to create an environment that you can heal in. So we're trying to create space. We're trying to decompress that area that's been injured and just allow the body to have some space to heal. So there's obviously the manual treatment that needs to occur there, but there's some load modification, some activity modification that we need to bring into it as well. But you get that right, and you get that right consistently, and some good things happen. So, we are getting a bit technical today. I hope that it's not too technical for people to listen to, but it's a good example, because it's a common thing and it's a big problem. It's not getting any better in general. But if someone with this problem doesn't land in our office, this problem isn't going away.
It's getting worse. I mean, it's turning into you, right? I mean,
yes, it's progressive.
That's the difference, right? And that's you were an individual that we could have easily fixed. You were somebody that we could have avoided surgery with. You were somebody that we could have, not that I would suggest to anybody doing the volume and stupidity of intensity of CrossFit that you were doing, but we could have at least enabled you to do that if we really, really wanted to, until maybe you accumulated then again enough adhesion to where we had this problem again. But I mean, I don't know what your goals are. Your goals are different now than they were 10 years ago, but you could have been somebody that we could have enabled to go ahead and chase those goals and, be more human and not need surgery and not need to be, in the library going, oh shit, what's going on? Am I going to crap my pants or be able to get a freaking erection for the rest of my life?
Which there's no problems with, by the way.
Yeah,
it's a good result.
That's not what Vera told me the other day.
So look, yeah, it's a crappy tale, I suppose, to have to tell, because yes, it should have had a better outcome. It's not a bad outcome, but it's not the best outcome. But it's worth revisiting that and kind of discussing what could have been done, because there's a lot of people that are right there right now that we can catch it right there right now and turn that around. And there will be potentially in that person some level of change, some level of degeneration. You're not getting a perfect spine back, but you're getting the best version of what you've got right now.
Right.
So I think that's kind of the point that I wanted to make today. We have the abilities now. We have the skill set to actually reverse some of this problem and kind of get it out of there and give you the best version of yourself at this point in time. Unfortunately, some of the more common treatments and the ones that people are walking into day by day, they're not looking at this. And so that's what we needed to highlight today, that we've got something that's a little bit different, and we want to share that.
Yeah. I mean, finding the right person and listening to the right person will change your life. So
that'll do us for another week.
All right, guys, have an awesome week. Have an awesome day. We were a little technical, but we kept it shorter to make up for the brain cells.
All right. We'll be back hopefully with something a bit more palatable next week.
See you guys.